Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. J. Calvert. Today, I'm here with my fully scrub changed out and cutified co-host, Dr. Millicent Rovelo. I think these scrubs are better fitting than the ones that you came from St. John's wearing. So, good move.
Thanks. Thank you very much. Yeah, I had a case over at the hospital this morning, so I had my hospital issue blue baggy scrubs. And I thought was hysterical is that our scribe who works in our office, she's a recent college grad. Her only medical experience really is this Beverly Hills Plastic Surgery Center. And she's like, "Oh my gosh, Dr. Rovelo, your scrubs are so big on you. You look like a real doctor." So what did I do? I promptly changed into my figs
That's right.
outfit.
Exactly. It's like, wait, I can't wear these on for the podcast. It's not going to work.
I need my figs.
I know.
So we had my surgery fit.
You need it. I'm telling you, it is a big deal. And it is funny, though, that our scribes see medicine as Beverly Hills plastic surgery.
I hate to break their little hearts and their dreams.
It's just not that way.
I know you're applying to medical school, but just so you know, this is not it.
No.
For the majority of what you're going to see and do. It's a huge part, to be fair. Like, I know a lot of people don't believe it, even my mom included, don't think we're real doctors. She was like, "Oh, I didn't know plastic surgeons were doctors." Yes, Mom, actually we are.
I think it's like a different career track.
She did. She's like, "I didn't realize you guys went to medical school." Anyways, yes, plastic surgeons, we are real doctors too. But as our scribes will learn very quickly when they go to medical school and do their residencies, there's a huge, wider area of medicine as well.
If you weren't going to be a plastic surgeon, what were you going to do?
Ooh, I have like 6 parallel lives.
Wow.
I know you asked for one. For a long time, I wanted to be like something in the fashion world, so like a fashion writer. But then I skewed more towards a costume designer, and that is still my like favorite alternative parallel life dream to do, like research, right? Because it's like kind of intellectual. So like, what did Russian girls wear in 1994? Or, what did they wear in 1776 Paris? And so like delve into that and then design it and do it for stage or for TV or whatever. I thought that'd be super cool.
That's sort of a reconstructive type of thing too.
It
So
is.
that's good.
Yeah. How about you?
I was going to play in a band. I love playing guitar. Still do.
Yeah.
That was the other choice. It was either musician or medicine, and I think I chose wisely.
I think we did okay.
Yeah. No,
I think we made the right choices.
I love what I do. I absolutely would do it again. Because I can still play music. Mm-hmm.
And I can still play dress up.
That's right. You do all the costumes you want. But and it's true. It's you have to really be willing to sacrifice a chunk of your life to the training to become a surgeon, first of all, but to just become a doctor.
Become a doctor.
A doctor is, it is a
huge sacrifice.
Yeah.
And so you have to love it. I mean, otherwise it really is just a job. And for the work you're putting in, it's not worth it. So you got to love it.
No, if you want money, go to Wall Street. They have a lot of money there. Mm-hmm. That's why I tell everybody that. If you think you're going to make money doing medicine, think again. You can do great. I mean, I'm not complaining at all. But I think if money is your focus, medicine is a terrible choice.
Terrible. Terrible.
It's getting worse.
By the second.
Every day. I mean, every day that the insurers say, we're not paying. And they are at the point where they just don't want to pay for anything. And so everybody's going to this cash system, which is going to make it even, I don't know, maybe it'll make it better. Maybe if it goes to market forces, that might be better.
Save it for the next podcast.
Okay.
What are we talking about today, Dr. J?
I want to talk about brow lifts.
Ooh.
And
it's a good one.
It is. I think brow lifts are important because they're misunderstood. In fact, one of our I won't say who it was, but one of the people that has come through to be educated in our center said, well, where I'm from, they just say brow lifts don't work.
Oh, wow. That's a big statement.
Yeah. And I think that our guest speaker at one of our meetings said the same thing. Coming from they said, we've abandoned brow lifts. They just don't work.
I remember that. Yeah, they were all about like rejuvenating the upper eyelid and doing fat transfers and skin excisions. But yeah, they'd kind of stop doing the brows completely.
So, as a guy who loves brow lifts, I have to disagree and say that brow lifts can be really powerful. I think they look really great. I think if they're done correctly, and that's probably why they fail for a lot of these people, is they just don't quite understand how to get the movement that they're looking for. I mean, you've seen it. You see it up close and personal, as a matter of fact. I mean, it's doable.
Yeah. So let's break down exactly what we're talking about here. So it's basically what it sounds like. A brow lift is a brow lift. They're talking about the eyebrows. So this is probably one of the first signs of aging in the face. It happens in late 30s, early 40s. The brow starts to descend, and it gives patients sometimes an angry look, or it can just make them look kind of tired. And it's a very aging appearance to the face. And even if patients can't pinpoint why, that is one of the main reasons, is that the brow has started to descend. And if you are someone that does a lot of Botox of the forehead, it can make it worse because the function, so the muscle of the forehead, it's called the frontalis. When you paralyze that muscle with Botox, you prevent it from doing its job. And its one job is to raise the eyebrows. So if you paralyze it or weaken it with Botox, the eyebrows drop even more. And so usually those are the patients that really first start to see or feel that their brows are descending because they are actively weakening their frontalis. That being said, if your brows are dropping and you're not Botoxing, your frontalis is working really hard to keep your eyebrows up. And so now you're getting wrinkles in your forehead because your frontalis is working so hard to keep your eyebrows up. So, I don't know, you got to choose your poison. Do you want to have a smooth forehead and your eyebrows dropped? Or do you want to have wrinkles on your forehead and your eyebrows in the proper position?
Or do you want to have the best of both worlds and have a brow lift?
And still get your Botox.
That's right. Well, and that's the thing. In fact, I had a patient who texted me and was like, I don't ever want to have Botox again. Can't we raise these brows anymore? And I was like, well, we can. I mean, you can raise them up really high where you look surprised. And that's sort of been the fear of many people that have brow lifts, is they're like, well, I don't want to look surprised.
Right. Because that was very much a look back in the day with old school brow lifts.
70s, 80s.
Yes. They just looked like they were constantly surprised to see you.
And that's because that was done as a coronal brow lift, which meant that the surgeon made an incision basically from ear to ear up in the hair and would peel the whole front of the forehead down.
Yep.
And in fact, in
it's
some
like skin your forehead.
Yeah, basically it was a scalping move, and it would bring your whole the entire flap down, and you would release the periosteum. In fact, they would trim muscle out. They would actually take out little bits of the frontalis muscle. Sometimes they take out corrugators and procerus, and then they would lift and cut skin away. And so the skin would be taken away, be an inch of skin sometimes. And man, did those brows came up.
I mean, they moved. They got them to move. But yeah.
Not my favorite way of doing a brow lift.
You seem dubious.
You seem surprised.
You seem surprised.
That's right. Oh man, we absolutely have to get the that scene into this somewhere.
You had a question?
Yeah. No, just help me. Help me, doctor.
What? You seem dubious.
Oh, no, not at all. I mean, I hear you're the best, Dr. Maccabee.
So I don't love the coronal brow. I
don't know. I mean, does anybody do the coronal brow?
I'm sure somebody does.
Somebody does out there. I have to say, in my training, I haven't come across it other than for like a traumatic, fracture reduction.
Yeah, and we do coronals on our facial feminization procedures when we do reduction of the frontal bone and the bossing of the forehead. So we do coronals, but for a brow lift is very difficult to get it to not look weird and unnatural. Now, then there's the endoscopic brow lift, which
Endobrow.
is that's sort of what I do, and you do. You like that. I think this is where you're down on the bones, over the frontal bone.
And these are small incisions, so we're talking like, 1.5 centimeters or something. Just 1, 2, 3, 4, or sometimes just 2.
Just 2, yeah.
Across
lateral.
the, top of the scalp hidden in the hairline, behind the hairline.
Yeah, the last few that I've done, and I've done 4 in the last 2 weeks, they're about an inch, 3 centimeters. And I've just done lateral ones. In fact, I've been able to do lateral ones and raise the peak of the brow and the lateral brow through a single incision, which I really love. And I've used the Endotine device even laterally. It's a little tricky, but I've been able to do that. And I have no financial interest in the Endotine company or whoever, I don't even know who makes it, but I do like the device because it's a way of fixating the brow in a good position after releasing the periosteum. So you use a scope, we use a camera, and we make those small incisions. We get down on the bones and get over to the ridge, basically, of the frontal bone. If we have to go all the way across, then you want to use the scope so you can see the nerve bundles, the neurovascular bundle. There's a nerve and an artery and vein coming out of 4 locations above the brow. And you release the tissue, and man, does that brow move.
It moves.
It moves good. And you can put it where you want it, and you can tailor it with those. If you're doing a medial brow lift along with the lateral, then you can use that medial port to kind of get the excursion that you want on the medial brow. And what I find is that you can really contour it quite accurately.
Yeah, and not everybody needs the entire brow lifted. Some people just need the outer edges. That's the lateral brow. Some people, if the inner corners or the middle portions of the eyebrow have descended as well, then they get the full 3 incisions. It doesn't make a difference, really. These incisions are small, they're well hidden. All that matters is that you're getting the right pull in the right direction, and whether that's just on the outside or the entire brow, that's individual to each patient.
And it's effective. It works well. I don't see them falling down. In fact, I spoke to one of the patients that I did in my first year in California after I came from Pittsburgh. I did a endo brow and mid face on one of my colleagues at UC Irvine, and she is now a lot older. And she texted me and said, "Hey, I need somebody to clean up my neck. I moved up north and blah blah blah. Do you have somebody? I'm not going to travel down there because I'm 80, basically." And I was like, "No, but how's the upper face?" She goes, "Oh, the upper face is just like you left it." And that's
great.
That was 2001.
Yeah, so it stayed. Now, in the beginning, it looks a lot higher because it's so. I think that's why people sometimes say they think it falls, because the first week or so, they really are kind of sitting up a lot higher because things are swollen. It's really swollen, and then as the swelling comes down, they do quote drop, but that's really just them coming back to the position you put them in to start out with. So maybe that's what people think of sometimes when they say it drops, but it doesn't. Once it settles down to where it's supposed to be, it tends to stay there.
Yeah, and so the endo brow is great, and I often do it with the mid-face lift, where I lift the cheek or release the entire mid-face and lift the whole shebang and get this entire area rejuvenated through one tiny small incision. The other way to do the brow that I want to mention is doing a subcutaneous brow lift, which is very straightforward. Right. This is where you just go under the skin, over the muscle, and you just lift the skin up, and you can tailor the brow. And in fact, that's the method I use when somebody says, "Boy, I'd just like a little more elevation here." Well, we already did the endoscopic entire flap elevation, and if it's not enough, then what I'll do is I'll make a hairline incision, and I will go down in the subcutaneous plane, and then I can trim a little skin out at the hairline and do it that way. And some people do need that. Some people want it a little more extreme, and if you do, then that's kind of how you can get that without having to re-elevate the entire flap. It works well. Biggest problem with brow lifts that I have, and I see it a lot, is nerve weakness. And they happen.
It's a thing.
It is. I just tell people, be prepared for it. If it happens, if one of your eyebrows isn't moving, the other one is, and you look like Mr. Spock, then we're going to Botox the Mr. Spock side until the other side wakes up.
Yeah, I mean, there's the nerve. The frontal nerve runs right through that area. This is a nerve that supplies sensation to the frontalis, the muscle that actually elevates the brows. So if one side gets knocked out temporarily, that side will drop, and the other side will kind of overcompensate. So one's high, one's low. It's temporary. These nerves are very rarely actually cut or transected.
Right. They're
Usually
not,
they're
as far
just
as I could tell.
bruised, they're swollen, they're a little traumatized, they're sleepy. they wake up, give them some time, you Botox the other side, do some exercises on the weak side to get it to kind of wake up. And it does. It always does.
Yeah, I mean, they've all come back for me. I haven't seen any, I've just never seen any residual weakness. I have seen, people say, well, how often does that happen? I go, more than I'd like, that's for sure. But, you think about it, you're putting all kinds of local anesthesia into these areas. You're elevating everything. The nerves are going to get stretched by the dissection itself. They get weak. It's not the end of the world. People kind of don't want their brows to move anyway, but you do want the frontalis action because it's part of the elevation of the brow. So I don't tell people they shouldn't assess their brow lift results until they're about 4, 5, 6 months out and you have full motion, all the edema's out. I think that it's at least 5 to 6 months before that's the case. And if you wait on that, then you can get a full evaluation whether you like the result. I still see a change on everybody over the year. I mean, I watch, everybody that I've operated on and watch how every time they come back, I look at where their face is and what's going on. And there's a lot of changes as they heal. There's scar tissue that forms. There's contraction of the myofibrils in the scar tissue that's being formed that doesn't happen until 9 to 12 months after surgery. So judging a result on any kind of lifting procedure, facelift, brow lift, mid-facelift, until you're kind of a year out, I think it's sort of early to do it, and you're going to be hitting a moving target if you start reacting to it.
Oh, yeah, no, for sure. You got to give it that much time at least. And the surgery it can be done on its own. It can be done with a facelift, which is usually when it's most commonly done. But it's up to you how much you want to do. If you're doing it on your own or on its own, you're going to be a little sore, a little swollen for a couple days, a little bruised. Most patients just say they have a headache. That's what I hear most commonly. I just have a headache. Well, we did drill some holes in your head. Sorry about that. Don't worry. You're going to love it.
Drill holes in your head. Don't say that. You're going to scare everybody away.
We don't drill holes.
You drilled the outer table of the bone. That's it. You didn't drill a hole in their head.
Not into their head. But there is some work on...
Oh, man. So who wants a brow lift? Me. I'll take one. I want some holes in my head.
I need that like I need a hole in my head. I think that's the expression.
You are going to need a hole in your head if you want that brow lift. No, it is
not a
a
hole.
very, very minor tab.
It is.
It's
and a real suture. So it's tiny. It's minuscule. But it allows patients to understand, why they have a headache.
100%. Because it does hurt a little bit.
It does hurt. Yeah. I mean, yeah.
But it's like a headache. It's not
like
terrible.
A headache. Yeah. And, a couple of days it feels okay. A little swollen,
Take
a little
some ibuprofen.
bruised. Yeah. And within a week, you could be back to work if you wanted to be seen in public.
Or 2 days later, depending on whether you're Dr. Rovelo or not. Just depends on.
If you're totally okay looking swollen, bruised, beaten up, and you have a job to do, go back in
2 days is good. Perfect. Don't worry about it. Throw that case on. I'll be right there. But yeah, most people I tell them a week.
Yeah.
And you can go back. I mean, I just had a patient I posted on TikTok or something or on Instagram where she was able to go to like a charity gala, 10 days after the operation.
That's kind of close. It's possible. Not recommended.
Not recommended, but she did do full makeup. And I showed the pictures and her cheeks are definitely, because the swelling goes south.
Yeah.
It does. And she had the mid-face with the brow. So, it's a great operation. I think it does work. I don't look at my brow lifts like, oh man, that didn't do anything. It does. And you just have to give it the time to heal. You have to, wait. And I will say that there are some people who do want a more lift that I wind up doing some skin lifts on. It's not a big deal. You do it under local anesthesia. It works.
Yeah.
It does get them the little extra if they want it. But I think you got to wait that good year before you really decide you want that. Because if you overlift it, can't bring it back down.
Can't. Yeah, there's no way of really fixing that.
And one of my most recent patients, I will also add, had blepharoplasty about 4 years ago. And she heard one of our other brow lift or mid-facelift podcasts and said that after her blepharoplasty, she just had the upper lids done, that her brow came down. She looked mean. And she looked angry. Because
that's
they did not do the brow with the lids.
With the lid. And so the reason for that, so these are patients that have extra eyelid skin and they have brow ptosis. Their brows have dropped. But because they have all that extra skin on their eyelids, their frontalis, their forehead, is working overtime to raise the eyebrows and get that extra skin off their eyelids. So it kind of masks how low the brows naturally sit. And then when you take the extra skin away and the brows don't have to work so hard to keep the extra skin off your eyelids, now they sit in their natural position, which is low. And so they're like, wait, why do I look so angry all of a sudden? And I saw a patient like that last week in my other office. She came in because she had had a blepharoplasty 4 years prior, and she had what she thought was recurrence of her extra skin. She'd have a little bit of extra on the outside of her lids, but really the problem was that her brows were sitting really low, and she was very upset to hear that she would need to have a surgery, which was now not covered by her insurance, because sometimes insurance covers the upper eyelid surgery.
Brouch.
And so
She wasn't happy with that.
yeah, and patients that come in and try to have this done with insurance on the upper eyelids, they get very upset when I tell them that they also need to have a brow lift, because they're like, well, doesn't insurance cover that? And like, insurance doesn't really care about your brows.
I've had insurance cover brow lifts in rare cases.
Rare cases, and the only time I've seen it is if they do it through an open approach, like right over the eyebrows, like old-fashioned, like cut it right above the eyebrows, leave a incision right above your eyebrows on your face.
Just like the reverse abdominoplasty.
Yeah, I've seen that done and covered. Or maybe just because the surgeon didn't want to put too much work and effort into an insurance-based brow lift.
Ugh, I don't like that operation.
No.
Have I done it? Yes.
It's an option, but we're not talking about it on this podcast because we don't do it.
Yeah, that's called a direct brow lift.
Literally what it sounds like.
And there have been occasions, mostly like at the VA, where you're trying to get the brow out of people's eyes, where you can use one of the forehead creases to do that.
If you're older and you already have some deep formed creases, that's very possible. And if you don't really care if you have a scar on your lift, it does the job.
Yeah, and I guess I've got the rare case where I'm doing a pre-trichal incision to advance the hairline, to bring the hair forward and do the brow lift simultaneously. Those are tricky though, because you're trying to get a balance. You're trying to bring the hair-bearing scalp forward and do the lift at the same time.
Yeah, it's tricky.
I've tried it. I've been moderately to very successful with it, but more moderate because it's hard to balance.
Right.
And you can't get the shape of the brow as much as you can when you're doing an endo. And like with the endo brow, I've got control. Like I've got really good control with it. And with the pre-trichal and a coronal, it's like it makes them look goosed. Makes it look like somebody came behind them and grabbed their butt. It's not cool. It's not a good look. Hey, good to see ya.
Still good to see you.
Yeah.
Still.
No, really. Are we having lunch? It's not cute.
No, but it can be done. It can be done well, and the results can last. So just check it out. See what your surgeon has to say about it.
Yeah, we have. I think on my Instagram, I have a whole lot of stuff about that, and also on my TikTok now, I'm starting to put more instructional videos there that sort of walk through the thinking behind these operations and where the incisions are, and I think the concept that it doesn't work is just not true.
This is not true.
It's not true for me. It's not my reality. It's not my truth.
You have to speak your truth.
I have to speak my truth. And that's why we're here on the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.